So my name is Steph. I am the nurse clinician on the transition and linking to care team. And I'm here with my colleague, Sarah, who I'll let introduce herself.
Hi, everyone. I've gotten to meet a number of you, so nice to see your faces. I'm the occupational therapist on our transition and linking to care team, and I'll let Steph finish explaining a bit about our project, as some of you may already know.
So today we're here, part of the Missing Middle project on the transition and linking to care team. So like Sarah said, you've probably seen us around Richmond Hospital and in the community. We are here doing some education. So you might have seen us at your huddles. You might have seen some of our emails with some education or our team site. And then, of course, you might have seen us at our first education session, which was Demystifying Working with Young People, Part 1. So today we are here talking about demystifying working with young people, part 2. The goal of our project at Richmond is to increase staff's capacity working with 16 to 24-year-olds with mental health and substance use concerns, as well as their families, to improve their experience. So that is why we're here doing some more formal education. And this will be kind of continued for the next 6 months or so. And so you'll see us popping up quite frequently in your feed and through email with some more future education.
Amazing. So I might move forward from the pre-survey screen unless anyone still needs to scan. I'll wait about 5 seconds to hear any protest. Perfect. So before we begin, we just want to acknowledge that Richmond Hospital operates on the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations, acknowledging that these lands have been places of living and learning since time immemorial. And so we are very grateful to be gathered here today to continue learning together and acknowledge that we are guests on this land. So before we get started with learning objectives, for anyone that doesn't use Microsoft Teams as often as Zoom, it operates really similar to Zoom. So you'll see there's a chat box if you want to put questions in the chat. There's a react option for thumbs up, things like that. There's options to raise your hand if you have a question or a comment. So just to kind of play around with that, I'm wondering, with a show of hands, if you raise your hand, how many people here attended our part 1 of our education session?
Awesome. I see a couple hands, yeah.
Seeing a couple hands there. And then if you can go to the chat box, I'm wondering if you could just rate, on a scale, if you're comfortable sharing in the group, on a scale from 1 to 10, how confident do you currently feel kind of engaging with and working with people that are 16 to 24 that you see in your practice? So 10 is very, very confident. I'm a pro. 1 is maybe not at all confident. Just curious if people are comfortable sharing in the chat where they're currently at. Totally. I would say, even though this is Steph and I's bread and butter, I never rank myself as a 10 in this, right? I think things are always changing, and we're all always continuing to learn. We also just want to acknowledge the knowledge in the room today. And so there'll be a lot of opportunities for group discussions to share your experiences and your knowledge. And we acknowledge that certain parts of this may be relevant more to some settings than others. And so we are trying to cater to hospital and community, but we're just really excited to learn from all of you as well. So there'll be plenty of chance to be able to share some of your thoughts too. And thanks for sharing those numbers in the chat. Appreciate that. So really quickly, today we're hoping to that by the end of today, you'll be able to identify positive childhood experiences, or PCEs, and how these can buffer the impacts of adversity on young people. We'd like to identify strategies to develop therapeutic rapport with young people, practice strategies to communicate and engage, understand how social contagion and group dynamics can impact treatment. This is huge with this age group. I think we all know that. And then identifying strategies for managing contagion and group dynamics as well. And Steph and I aren't easily distracted. So if you do have a question or a really relevant comment, don't feel like you have to hold it till the end. Please raise your hand or just unmute. We're happy to have some discussions and questions throughout, and we'll make sure there's a bit of time at the end as well. So in our last session, for those of you who attended, we learned how adverse childhood experiences, or ACEs, can impact lifelong health outcomes. This is something that's talked about a lot. We know that experiences of trauma or adverse experiences can have lifelong impacts for people. But what's often not talked about as much is how there are some individuals with high ACEs scores who grow up to have normal development and stable emotional health. So researchers at Johns Hopkins were curious about this, and they've identified 7 resiliency factors that help children thrive despite difficult childhoods. And this is hugely relevant for all of us because assessing, promoting, and leveraging these positive childhood experiences, or PCEs, may reduce adult health problems, even in the presence of ACEs that they've experienced. And so what are those 7 resiliency factors? So the ability to talk with family about feelings, right? So many young people don't feel comfortable, like they might get in trouble, or like their parents just don't understand, or are really quick to try to fix and not there to listen. And so the ability for a young person to feel like they can talk to family about feelings is huge. The sense that family is supportive during difficult times. The enjoyment of participation in community traditions. This could be more community traditions in the sense of cultural continuity, really engaging with faith or with culture, but also with community traditions. Are they involved in something at their community center? Do they know the people in their neighborhood, or is there some sort of larger community outside of school that they're part of? Feeling a sense of belonging in high school. Feeling supported by friends. We know that bullying can be huge at this age group, whether it's in person or increasingly online and cyberbullying, but feeling supported by friends and feeling a sense of belonging can really help cope with some of those stressors for young people. Having at least 2 non-parent adults who genuinely care. This can be someone like a coach, someone like a teacher, if they're part of anything like Big Brothers, Big Sisters, right, where there's mentorship from other kind of older figures in their life that they can look up to and feel supported by. And feeling safe and protected by an adult in the home. So knowing that we're not in person, we won't get you to turn to the person beside you, but if you're comfortable throwing it in the chat or unmuting, we'd love to kind of just have a bit of a group discussion about how can we promote and leverage these positive childhood experiences with children and young people we see in our practice. And then what are some other protective factors we can foster to minimize the impacts of ACEs? If there's anything you think we've missed from this list, or things that you've found in your practice that can be helpful. I know we are over lunch hour too, and so some people are eating food and lunch while they talk, so it might be a bit harder to unmute, but if anyone wants to write in the chat, there's no wrong answers, but just looking back at these, the ability to talk about with family about feelings, sense of belonging in high school, support by friends. Curious if anybody has done already or has ideas for how we might be able to promote some of those factors with the young people and families we see. Hi, Flora. Thanks for joining us. Oh. Hello. We've just gotten started. We're just talking about positive childhood experiences, how to potentially buffer the effects of difficult or adverse childhood experiences with young people.
So maybe while some people are percolating, so some of the things that have been brought up in previous sessions were connection to community support, like community activities, or like sports teams was a really big one. Activities in school, extracurricular, and I just see in the chat helping children and young people identify role models and the qualities that they want to emulate. That's a great, yeah, and that's exactly what we're looking for when we're talking about having people outside the home that they trust and can talk to. And then we can perhaps explore or identify PCEs that have occurred in their lives. Totally, yeah. So what are they already doing that's working for them? Can we do more of that, or is there other things that we can be supporting them with? Totally.
I think, as we all know, in the healthcare system, we can take a really deficit focused approach on what are the things that are going wrong. But yeah, I really like Bryce's comment in the chat, like what are the things that are going well, or what are those things that we can continue to build on or foster more of? Feel free to continue if you want to unmute and share more or post in the chat. Some other ideas we've heard. So parent or family education on how to make space for young people to discuss their feelings. So a really famous and evidence-informed form of training is emotion-focused family therapy. There are additional courses you can take on that if you're interested. We will have some resources at the end. A lesser intense version of that, because a person does need to have some certifications, is just the concept of emotion coaching. There are very much some emotion coaching skills that a clinician can work on and strategies with those parents without having the full EFFT certification. And so how can we kind of coach parents in how to respond if a young person is feeling big emotions? How can they get them to begin talking about those? Exploring with young people if they have other adults they trust who they can reach out to for support. So I think Chandra's comment was touching on this, right? You know, is there someone else in your life you'd feel comfortable going to? And I think thinking about all of us, if I had a young person in my life, like a cousin or a family friend, and they reached out to me looking for a bit of support or mentorship, I would be like really flattered and just really, really happy to be there for them. And so I think a lot of adults in these young people's lives want to be there for them. Supporting connection to friends, school, or community activities. We know that with things like anxiety, depression, or more serious forms of mental health, one of the first things we might do is turn inwards and, you know, want to isolate ourselves. But we know that that connection and reaching out to people for help is one of those things that we do really need in those moments. And connecting families to parent support resources wherever possible. We'll have some resources listed at the end of here, but yeah, parent support resources, whether it's a parent peer support worker with lived experience who has also had a young person they've supported with mental health, substance use, who can just be there and be someone that can support and help them navigate resources, or that's other things like parent support groups, ways to just build up that resiliency of the parents, the caregivers, and the young person. And really quickly, some other protective factors, fostering community connection and support, like we've talked about, connection to trauma-informed care services. And so I think we all endeavor to be trauma-informed in our practice, no matter what setting a young person is reaching out to, but acknowledging that in the cases where someone has had significant trauma in the past or adverse childhood experiences, there are times where referring to more trauma-specific resources can be helpful as well. And lastly, just making space for the acknowledgement of how it has impacted them. If any of you are familiar with Bessel van der Kolk, he's a trauma expert, a psychiatrist, and a neuroscientist, and he's most well known kind of around the media and in circles by writing the book, The Body Keeps the Score. But in his book, he talks a lot about how a key part of healing and moving forward from trauma is in just making an acknowledgement and making space for the fact that it has impacted a person and allowing them to weave that into their life story as they move forward and heal from it. And so if a young person is disclosing things like this with us in our roles, just checking in and saying, hey, that sounds like it was really difficult. That's the type of thing no one should have to go through. But I'm really glad that you told me. Do you feel like this continues to impact you, or do you feel like there are more resources or things you need to kind of unpack and understand that? Any other questions around positive childhood experiences before we go to our next section? Or any other comments or experience in the room anyone wants to share? Okay, I'll hand things over to Steph.
All right, so next we're going to be working on some strategies to develop a therapeutic alliance with young people. So before we do that, just to have a brief kind of conversation or discussion about why we think engagement is so important when we're working with young people. So as Sarah's mentioned before, feel free to throw it in the chat or unmute yourself. So why do we think being able to engage a young person is so important for their care?
I guess, most of the young people I work with are adults, so they're all 19 and over. But again, I think it would hold true for the 16 to 19-year-olds. It's that sense of, building a bridge so they feel safe and comfortable. I think, from the some of the young people I work with can feel awkward or they haven't had a safe space to talk. So, really taking some time to really build that engagement and that connection so that, so they feel safe being able to share. Oftentimes, they're more connected with their peer group. It might be difficult to talk to an adult, especially an older adult, some of the young people I work with. So, yeah.
Thanks for that, Deborah. I think you highlight a really important part when we're working with young people is that it can take a little bit more time, especially if they haven't utilized mental health services before, if this is their first time or they're anxious about the unknown. What are you going to ask me? What kind of questions they're going to be? What are we going to talk about? Versus someone who maybe has been to a community service or the hospital multiple times. They kind of know the drill, right? What are you going to ask me? You kind of have an expectation. So it can take a little bit more time when it's someone's first time opening up about this. And you may be the first person that they've ever talked to about some of these difficult situations, right? And then I see in the chat, to develop trust. Yeah, I don't think anybody is able to develop trust immediately when they meet someone. So this can take, once again, a little bit more time. And if someone trusts you, they're probably more likely to share information or personal information with you, and trust that you're going to support them with that, right? Is there any other thoughts on this about why engagement is so important with young people? Yes, Bryce, your comment's great. So their focus and engagement may be more limited than adults. Yes, especially when we're looking at maybe the younger population. Maybe there is maybe there's some ADHD going on or some other diagnoses going on, and so their attention span might not be as long as an adult's, and so that might look a little bit different. So if we are able to engage them, then we can sometimes keep them talking a little bit longer to understand what's going on. I see Chandra's typing, so I'll give you a moment to do that. And Sarah, if you're able to press next, maybe we'll go that. So some of the things that I've already mentioned. So this is possibly their first experience with the mental health system. So it's really difficult when you don't know what to expect. Yeah, and then Chandra, I see your comment, to provide them with support that they may not be able to find from their caregivers. Yeah. So this was something coming back to what Sarah talked about with PCEs, is making sure that we have somebody, if maybe their parents are not the person that they trust to talk to, right? How can they talk about their feelings? Who can they talk to? So making sure that there is some support, because we know that if a parent is having difficult times with their own mental health, they might not be the person that the child can turn to at that time, or the young person, right? And then engagement and developing rapport can take time. So this is something that we really try to reiterate when we're doing this education, that doing an assessment with someone who is maybe 16 or 17, 18 may take a little bit longer than someone who's 40 to 45, because they already have the experience of working with the mental health system. So their experience can determine their future trajectory in the system. So if somebody is able to engage with a clinician and get that support and get help with their mental health, their outcome with their mental health is probably going to be more positive than somebody who's not able to engage, not able to open up and talk about what's really going on. So a poor negative experience could prevent them from returning to any services. And if they don't return voluntarily, then we may be looking at a situation, especially in the hospital, where they are going to have to return involuntarily. And that we know is not as good for health outcomes, because they might not want to engage when they've been forced to have to engage with mental health services under either under a Section 28, so being brought to hospital by police, or even certification by a psychiatrist in the hospital or in the community. So we always want to be looking at what can we do with people to get them to engage, so that we can get them to come to services voluntarily, so we can prevent that involuntary force in order to access services. Great, we'll go to the next one. Perfect. So some strategies that we've identified. So some of these, of course, will be review. I'm sure everybody knows how to introduce themselves and do their confidentiality statements, but we did want to just highlight some kind of tips and tricks and specifics for this population, specifically young people. So the introduction. So making sure that you're telling them who you are, what your role is, and what you're here to do. If you can imagine, if you've been to the hospital and even in the ER, the number of people that you meet from the moment you step through those doors, you've probably already been introduced to 6 other people. So it is important just to, as a reminder, to let them know like who you are and what you're going to do. My name is Steph, and I'm here to talk to you about why you're in the hospital for your mental health kind of thing. Asking the patient their name and if their name on the chart is the name that they like to go by. I can't tell you the number of times that patients have gone by either their middle name, a nickname, or something completely totally different. And this is a good opportunity as well for engagement, so that they know that they can trust you with their information, and letting them know that they can be their true selves with you if they have a different name that they like to go by. And if it is different, I always want to make sure that you thank them for telling you and then document this. It is different depending on where you document. I think most of the community teams are doing some sort of online documentation, but then in the hospital, there's paper documentation. So keeping in mind, where's the best option to put that? Is it the top of the chart? Is it somewhere else that everybody has access to, so that we all make sure that we're using the right names and pronouns? And then asking their pronouns and documenting this on their chart so that other staff can be aware. So this also comes into your introduction as well. How do you introduce yourself? So my name is Steph, and I usually wear a pronoun pin. I don't have my ID on right now, but usually I'll have a pin on that has my pronouns, and just making it very simplified and normalized for people to share that with you. And then once again, making sure that it's documented and clearly shared with the appropriate team members. So an example here at the bottom is, hi, my name is Dolly. I'm your nurse today. Is David the name you like to go by? And what pronouns do you like to use? So another thing that I like to point out to staff that are working with young people is also when they are present with a caregiver or a partner or a parent. Sometimes I will re-ask this question once I've got them by themselves, because I think we all know that there are some situations where parents or caregivers or other family members are not as supportive if they identify maybe as trans or non-binary, and they haven't come out to them yet. So I do always use this as an opportunity as well, once I've sat down with the person alone, just to say, like, just once again, is David the name you like to go by? Yes, no. And I think sometimes people are surprised to know that I've had a couple situations where people will say like, oh no, my parents aren't aware. I don't really want to tell them yet, but can you call me this while we talk kind of by ourselves in the room? So making sure that that is documented, but also making sure it's clear that there is an expectation that the parent or guardian or partner is not supposed to know about this. So the next section here is confidentiality. So once again, everybody knows the importance of making a confidentiality statement, but when we are working with young people, when we provide a confidentiality statement and let them know what confidentiality is and what happens when we have to breach confidentiality, I do find that it does build trust with the person that you're working with, because then you're explaining the limitations, the nuances, and they trust that you know when you can share information, but that if you have to share information or breach confidentiality, that it's going to be an ongoing conversation. So some examples of things would be self-harm and substance use. They can often be kept confidential from parents, but it does have to do with risk, right? So if someone's living with a parent, confidentiality with regards to anything around like self-harm or risk to themselves, we do have to have a certain level of communication, right? But we do explain that process. So I like to tell people that confidentiality is not a one-time statement. It's an ongoing conversation when we're talking about these difficult topics. So explaining the process of breaching confidentiality is an opportunity to build rapport. When we disclose when we disclose what needs to happen, we go to the patient first or the client, explain to them why we have to breach confidentiality, who we have to breach it to, and what information is going to be shared and with who. So an example of a confidentiality statement would be everything we talk about will be kept confidential between you and I, but that does exclude any safety concerns regarding you or anyone else. And so sometimes people will say, well, if I say this, are you going to have to tell somebody? So usually I'll talk through, okay, well, if you're using substances, that's not something that I have to share. That's a big one that I always get questions about. Are you going to tell my parents about me smoking weed or anything like that? So those are kind of the questions that sometimes we get after. Does anybody have any questions about that before we go on? Or any comments as well? Okay, I think we'll go to the next slide. Okay, so some more strategies. So validation. So you understand where the person is coming from, even if you disagree with what they're saying. So some examples of validating statements are, I hear what you're saying. It sounds like this was a really scary experience for you. And I don't have the same beliefs, but I can see this is really important to you. So validation, I find the earlier you do it, the more, the better the engagement likely will be. And I do find that this is a really helpful strategy, working with young people to let them know that you're trying your best to understand what's going on. But of course, we never really understand what anybody else is feeling, but you're attempting, it's that attempt that you're trying to understand. And that's usually half the battle with engagement, and letting them know that you're trying your best to understand. And then the next one here is normalization. So this is a way that we can help prevent, minimize, or reverse the psychological and behavioral manifestations of being viewed as different from society. So a couple examples of normalization would be when a person is feeling overwhelmed, low, or distressed. They may sometimes have thoughts of ending their lives or harming themselves. Have you been having any thoughts or urges like this? Another example would be low mood and anxiety are common human experiences. Seeking support and developing coping strategies can help you get through these hard times. So you're letting them know that they're not alone in this situation. There's other people that feel the same way. And similarly to how people respond in group therapy, knowing that other people feel the same way, this is a communication technique that you can use with young people to let them know kind of you're not alone in this. Other people, I've worked with other people that feel the same way or have shared similar experiences, and often that makes them feel a little bit better about and less alone in their situation. And so the next two we're going to talk about here are non-judgment and curiosity. So coming with a non-judgmental attitude, I like to use the phrase unconditional positive regard. I'm sure this is something that people have probably come across in their school or in their training. And it's the concept that no matter what a patient's behaviors are, you're not going to think any less positively about them. So you're able to separate the person from their behaviors, and still treat them with the respect that they deserve, and making sure that you see them in a positive light, that their behavior is not who they are as a person. So young people are often easily able to detect judgment from others, and if they don't feel accepted, they may not open up or be honest with you. And then non-judgmental listening is about giving the patient an opportunity to talk through their problems. It is not about telling them what you think or what they should do or not do. I don't know if anybody's had the experience of trying to tell a young person what to do. It doesn't usually go well, right? They might be resistive to what you have to say, and often if it's not something they're interested in, they're just going to completely disregard it, right? So it's understanding what they're hoping to get from this and what they are willing to do, and supporting them with that. So an example of a non-judgmental statement would be, that sounds like a really crappy situation. How do you think you want to deal with that? So supporting them to do what they are thinking that they might want to do, and kind of guiding them in that way instead of telling them what to do. And then the next one here is curiosity. So clinical curiosity is usually described as questing for information about patients, their conditions, and the processes and contexts affecting treatments and prognosis. So acknowledging you are not the expert in this situation, and then asking questions to better understand what's going on for them. So some examples of a curious mentality would be, how, if at all, does your depression affect your function in daily life? For example, with your school, friends, work, etc. What strategies have you tried to manage your anxious moments? And then you mentioned not doing the home/practice goals that we planned last session. When you left, you were really motivated. What do you think has been getting in your way? So these are some questions, as some examples of ways that you can bring curiosity to what is going on with a young person, and the way that you can phrase your questions. Next. So this is just an overview of the strategies that we've talked about. So the importance of an introduction, so who you are, what your role is, and what you're here to do. So an example here is, hi, I'm Val, I'm your nurse today. Is Quinn the name you like to go by? So making sure that we're getting proper names and pronouns. Confidentiality, so explaining confidentiality, what the limitations of confidentiality are, and the process of breaching confidentiality. And also looking at confidentiality as more than just a one-time statement. It's an ongoing conversation. Validation, so letting people know that they've been heard and that you're attempting to understand where they're coming from. normalization, so letting people know that other people feel the same way that they do or have had the same experiences and they're not alone in that experience. And in coming to interactions with young people with a non-judgmental and curious attitude.
Yeah, one thing I'll jump in and say here is, as some of you know, when we designed all of these training modules, we consulted clinicians, patients, families all across BC on what they really wanted to see and what they felt like education would be helpful in. And there was one parent we spoke with who had a young person who went through the mental health system in Richmond, and they said overall it was really positive, like some really, really good interaction and engagement with their young person, but they did have a dead name, or they were trans and they did have a name that they no longer went by and had a new name. And there's a few occasions within a few days of the wrong name being used. And so this was about a year or two after the event, and the family did still remember that. And so just like a highlight or a personal example of how the small things we do really do make a difference for these families.
Okay, so these are some more communication strategies. So using things like a process response. So this is a term that was kind of coined in the training that I got as a registered psychiatric nurse. But essentially what it is, it's a communication technique that combines reflection with an open-ended question to better understand where resistance may be coming from. So an example of this is, I notice you seem frustrated when you're talking about your parents. So that's where the reflection piece is coming from. What's going on for you right now? So that open-ended question. So you're kind of combining the two to get an understanding. I see what's going on. You're addressing, I notice you're not speaking to me. I notice you seem really frustrated or angry. I notice you're clenching your fists, or I notice that you're looking away and not answering my questions. Tell me what's going on. And so I do find with young people, especially, it is helpful to address that. Just to kind of put the nail on the head, like, I notice you're doing this, like what's going on. So letting them know you see what's going on and that you want to try to understand what's going on as well. And then the next part here is open-ended questions. So using questions that start with like things like how, instead of why, or what, and using how and what instead of questions with why. Oh, I see your note there. Yes, we are going to be sending out the slides. So if anybody is taking notes, and Sarah, I'll also get you to click next for the open-ended questions as well. So using questions that start with how or what instead of why, especially when we're looking at the, from a motivational interviewing perspective, asking why usually ends up putting the blame on someone versus how and what. It encourages a full answer. And then it prevents them from just saying yes or no. So it usually will give them the opportunity to expand more on what they're saying versus a close-ended question. And once again, why questions can be interpreted as judgmental and can often be reframed as a what question. So a couple examples of open-ended questions would be, tell me more about that. And in the example before, what's going on for you right now? And instead of using the statement or question, do you use any substances? I always recommend people try to use this statement, when was the last time you drank alcohol? So this is a bit of a normalization with an open-ended question. So often when you ask people difficult questions, when was the last time you had sex? When was the last time you used any substance? Or sorry, do you have sex? Do you have any substance use? Often you'll get an immediate no response, especially with young people. And when we're talking about confidentiality, we can kind of understand that. So when we use a statement that starts with when, then we're also normalizing it and making the assumption that, then kind of letting them know that we're assuming, and because of our experience, most people do use substances or have used substances. So it takes away that part about trying to create normalization through a previous statement by just asking when. And then that also gives them the opportunity to deny that too. Well, oh, I don't use any drugs, like I don't drink, kind of thing. And you're more likely to get an honest answer this way because of that phrasing. Does anybody have any questions about that before we move on to the discussion? No? Okay. I'll give it back to Sarah.
Yeah, so just a quick group discussion around some of these strategies. So Risha is brought to intake by her parents. She refuses to speak to the intake clinician, and her mom answers all the questions. Her mother mentions that Risha was hesitant to come in, and they had really pushed for her to join this program. When you enter the room, you notice Risha has her hood on with her parents quietly sitting next to her. You introduce yourself to Risha and her parents, Sherry and Raj. You ask to speak to Risha alone, and the parents exit the room. You introduce yourself to Risha, and when you ask her name, she doesn't make eye contact and doesn't answer your question. So, keeping this in mind, how do you feel when patients or clients don't engage with you? How does that make you feel as a clinician?
And feel free to put it in the chat as well, or put up your hand, or just unmute yourself.
I think with all of us being, many of you being quite well trained and knowledgeable, we might have learned to not have some automatic responses or reactions to this, but thinking about just the average person or a new grad or a new clinician, like how does it kind of just viscerally feel if people don't engage with you? It can be challenging, right? Any words come to mind? Nervous.
Nervous, yeah.
Yeah, nervous. How is the rest of this gonna go?
Self-doubt, yeah, that's a big one. What am I doing wrong? Like, what am I doing wrong as a clinician that this person doesn't want to talk to me? Yeah. Awkward, yeah. This
I think
entire assessment might be just us staring at each other, right? And not talking.
You might feel just as
Frustrated.
awkward as that young person sitting with you.
Yeah. Frustrated, yeah. Why won't they talk to me? You know, we have a 1 hour session. Come on, let's go. We have a lot of information to get through, right? That frustration and the time sensitive nature of almost all of our jobs, right? Like, we only have a certain number of time, a certain amount of time to do these things. Yeah. Confused, yeah. What's going on here? What is it, me? Is it them? Is it something else completely different? Yeah. And so with those feelings in mind, how do you think that you would proceed? What kind of things do you think you would do if you were sitting in a room with Risha with their hood up saying nothing to you when you introduce yourself? What do you think you would do?
Hint, these can be some of the strategies we've just talked about, or some other strategies that you've pulled in your practice.
So one of the things that we talked about was one of those process responses, right? So combining a reflection with an open-ended question. I noticed that you're not talking to me, and it seems like you don't really want to be here. Like, what's going on? Yeah. And then I see, okay, acknowledge that this may be difficult. Yeah, like it sucks that your parents forced you to bring here. Like, I can bring you here. I can see that you don't want to be here, but while I have you, like, maybe we can talk about what we can do to support you. Maybe do you have any questions before we start, right? Yeah.
Yeah,
See a couple people. Go ahead.
Yeah, I just, from listening to some of the other responses, like it sounds like a bit of validation and normalization of, hey, like, it can be really scary to come in and ask for help. And a lot of young people that come here, they might not feel like they want to be here. They might be pretty nervous. And so just know that you're not alone in that. And today we're just here to kind of get to know you a bit better and see if there's anything we could do. But we want you to feel comfortable here. And we know that you came here and it's been a bit of a frustrating experience being kind of dragged here by your parents. And so, yeah, validating that.
I have this little chart on the side, and obviously 16 to 24-year-olds are not children, but I did come across this, and I just found it really helpful, just as kind of a reminder sometimes as a clinician that there are reasons why people might not talk to you other than just simply, I don't want to talk to you. So a couple of examples would be something like anxiety, right? If you're really anxious and you're meeting someone for the first time and you're sitting in a room, like if you're really anxious, you might not be able to get the words out. You might not be able to voice what you are wanting to say in a way that they would understand. So sometimes we do see people get a little bit quiet or not able to answer questions because of that. anger. So this is what might be happening for Risha. We don't know because she hasn't told us, but you know, if your parents are dragging you somewhere and you don't want to be there, that would maybe make me feel really frustrated. So sometimes what we see with young people is that they think, oh, well, if my parents are going to drag me here, I'm just not going to talk. And we know that that doesn't really work in their favor. So sometimes I'll even tell people that, you know, if you're not going to tell me what's going on, then I can't really do anything for you right now. So why don't you let me know what's going on, and we can see how we can either get you out of the hospital or get you doing this or whatever the plan is, right? Some developmental deficits. We haven't talked to Risha yet, but we have probably looked at the chart. So we would probably be looking to see if there is any developmental challenges, right? Maybe her chart says that she's 18, but if there's a developmental challenge, maybe she has more of the mentality or understanding of maybe a 10 or a 12-year-old. So is the way that we're communicating, or even the way that we've set up this interaction, is that an appropriate way to talk to Risha? Just kind of questioning that as well. Physiological needs. This is huge. If you're hungry, tired, if you're thirsty, or you have to go to the washroom really bad, like, are you really going to want to sit in a room with someone and talk to them possibly for, 20 to 45 minutes? So, hey, like, when was the last time you ate? Can I get you something to drink? In the emergency department, I'm always bringing that juice around, those sandwiches. Just bring it instead of even asking, hey, like, I'm going to grab a sandwich. Can I grab you one, kind of thing? Those kind of offers. And then mental illness. So we understand that if someone has a severe mental illness, but for an example, something like psychosis, maybe there's something else going on right now that they can't attend to this assessment. They can't attend to this interaction. So trying to understand that maybe it isn't you, maybe it really is an underlying component of their mental illness, and that might just be an indication of why you're having trouble engaging. So these are just kind of reminders in the back of your mind when you find that people aren't engaging and you really feel like you're trying your best, introducing yourself, explaining, validating, and using these strategies. Sometimes it is really something that's outside of our control. So these are kind of some examples of situations that might be a little bit more outside our control, but then ways to manage that as well. And then I just see in the chat here, I like to ask young people what their dreams are for their life. Yeah, that's a huge strategy in psychiatry. I think what 3 wishes is something that I see a lot of clinicians use. If you had 3 wishes or 3 dreams, like what would you dream or wish for, right? Kind of seeing that and looking from a more strength-based approach, right? What can we do to get you there?
And building on Margot's comment, it sounds like it's almost a little bit too of just building rapport and getting to know them a little bit, having a bit of that small talk or talking about something they like before you get into some of these questions that can feel really invasive and pretty heavy. Yeah.
Yeah.
Okay.
And the last one, go ahead, Sarah.
No,
I was
go
going to
ahead.
say the last strategy that I sometimes like to use, especially so if you go through this list on the side here, they don't seem like they're anxious. It doesn't really seem like they're angry, and none of these other things seem to be a problem. Sometimes, especially with teenagers, is a strategy that I use is I like to use humor. So sometimes I'll use a process response, but add like a little bit of humor to it. Like, I noticed that you're not talking to me and your parents brought you here. So it's going to be a pretty long interview if we're both just staring at each other for the next 45 minutes, right? So bringing a little bit of that humor into it, be like, I don't really know what we're going to do if we just got to stare at each other. So, and sometimes I find teenagers will respond a little bit better to that. Just because you break the ice a little bit, you acknowledge, what, like, I get it, you don't want to be here, but it is what it is right now. Like, what can we do to make this better for you? Or maybe there's something else I can support you with. So sometimes using humor when appropriate can be a bit of an icebreaker for young people.
One of Steph's tricks that she's used and told me about that I really like is similar to the silence, is someone just saying, I don't know, over and over again, right? You're asking questions. Oh, I don't know. And Steph sometimes will say, oh, well, I don't know either. So what are we going to do? or yeah, where do we move forward from here? So again, very specific to your personal style, whether humor and judging with that young person if they'll respond well to it, but definitely lots of ways you can approach it. And I think we've touched on this a little bit. Any further comments, Steph, or I think we kind of jumped ahead?
Yeah, I guess just a question for the group then. If you have Risha, so she does start talking, you were able to break the ice a little bit, maybe you use some humor, maybe you kind of acknowledged or validated, yeah, like it's crappy you have to be here, it's a Saturday morning, I know you don't want to be here, kind of thing, right? And then she does start answering, but then she keeps saying, I don't know. So what kind of strategies might you use to engage Risha in discussion? So some of the examples that we used, or even some examples of things that you do in your own practice to engage somebody who's maybe saying, I don't know, or shrugging to most of your answer or your questions.
When that's happened in session for me, what I usually try and do is just shift out of trying to do an assessment or gather information and just try and connect. You know, just might be just asking them, how they felt today when they woke up, or trying to connect person to person and not just to sort of shift out of question asking and have it be more of a conversation. And try and get to know them, things that they like to do, something like that gives them an opportunity to share rather than feeling that they're being probed, I guess. And that's worked well for me in the past.
Yeah, that's a really great response. And it's kind of starting to make it more of a conversation, right? Because especially if you're the type of person who has maybe an assessment in front of them, or there's paper charting in front of you, it seems like, oh yeah, just ask question 1, question 2, question 3. So sometimes it seems to patients, especially like, oh, you're just reading off a piece of paper. Like, do you even understand like what you're doing? Do you know how to do your job, right? All those kind of comments, and treating it more like a conversation. Starting, like, how did you sleep last night? How's it going today? What were you doing before this appointment? What did you start your day out with? Did you already have a hard day at school, or did something happen this morning? Maybe you got a busted tire on your way in here and you're frustrated, right? So just kind of having that more conversation and treating them more like a person rather than an assessment that you have to complete. And usually you'll get a pretty good response with that, right? Any other examples? Awesome. Okay, I'll throw it back to Sarah.
Yeah, so the next section we'll go through is social contagion and social media. So what is social contagion? It's described and compared really similar to an infectious disease like COVID or anything like that, but it's the spread of behaviors, attitudes, and affect through social context passed from one member to another. People sometimes even describe social phenomenons or fashion trends or things as a bit of social contagion. So teenagers and young adults are more prone to social contagion than other groups. We know that they place a really high value on peer acceptance, and they also spend a lot of time on social media and on these platforms where they can spread these ideas. So researchers have observed social contagion impacts in many areas. Some of the ones with the most evidence are things like gun violence, bullying, violent offending, happiness levels, depression, self-harm, and suicide. So what that means is in networks of people, these sorts of phenomena are being passed in high schools or in friend groups or in pockets like that. A very common example of social contagion is suicide clusters, where suicidal behaviors in one or more people can increase the likelihood of subsequent suicidal behaviors in others. So contagion can occur 2 ways. It can occur directly or indirectly. If we're continuing with the example of suicide, a direct interaction might be something like actually knowing a person who commits suicide, maybe someone in their school. Indirect might be more like exposure to the concept of suicide through the media or the internet. So an example of this, for example, is there was a famous show on Netflix called 13 Reasons Why that was about a high school suicide, and there was documented increased cases of suicidal behavior after the show came out, and some even in a bit of a copycat format to what was done in the show. Use of social media has other considerations, right? We could talk about it all day and have a whole workshop just on that, but it can increase access to misleading or incorrect mental health advice. A recent study looking at TikTok and all of the videos sent around showed that about 80% of the mental health advice is either incorrect or misleading. And we also realized that using the internet or social media can leave young people in isolation without supports when they're exposed to traumatic content, such as graphic images or cyberbullying. Whether they're seeking out this content or they're accidentally stumbling across it in a timeline, we do know that there is a fair amount of that more graphic stuff out there, right? I've worked with a lot of young people who've said to me, oh, my parents were really busy working a lot, so I feel like in a way I was raised by the internet. They spent a lot of time looking for answers and going to the internet for those questions that in previous generations they might have gone to parents for, right? So with social contagion, what are some ways to help manage the impacts of contagion in your setting? So recognizing some of you are community, some of you are hospital, what are some ways to help manage the impacts of contagion in your setting? Feel free to type in the chat box or unmute. No wrong answers, just curious, any thoughts on this type of thing? So I might get the ball rolling with one idea, and then I see a couple people typing in the chat. So developing ground rules to avoid sharing of specific details related to triggering topics. So many of you, if not all of you, might be familiar with the fact that newspapers and the media are very, very intentional about the fact that they try not to report on suicides. Because it has been shown that when those are reported in the media, there can be an increase of cases in that area. And so whether you're in maybe, it could be like an outpatient setting where it's a residential unit, it might be, you know, if people are all working on their recovery around substance use, maybe there are ground rules around how much we can share around those topics, particularly if the sharing is around glamorizing those details. In cases of things like suicidal ideation, suicide attempts, self-harm, it might be making sure that there's no information about the means that people use for that, like anything that can give people ideas or like further glamorize around those topics. Margot, I just saw asking them when they find support in their life and whether it is helpful or not and what makes it helpful. Absolutely. So that's the thing. Social contagion can be a really positive thing too. I think you're making a really important point, Margot. It, you know, with where they're finding their information and their support, what kind of an influence is it having on them? Another idea building on what Margot has said is capitalizing on the positive impacts of social contagion. So at Richmond Hospital, on one of, it was the psychiatric assessment unit, there was two young girls there a few months ago who were under 18, and one of them was very depressed and did not want to engage, didn't want to eat any of her meals, and the other girl was sitting on the unit like, man, I'm bored. And she just kept going over to her and was like, hey, play cards with me. Hey, you should eat your food. And was kind of trying to form a bit of community, but was actually having a positive influence where she was helping kind of bring that other person out of their shell a little bit. Or on a group therapy type of situation, you might have one person who's really enthusiastic and talkative, and they might help bring out some of the more reserved or newer members of the group and make them feel like they can share, right?
I see Chandra's comment, provide education about contagion effects to clients and ask them if they might be being influenced by them either positively or negatively. Yeah, and I think that's exactly what Sarah just said, asking more questions to understand whether or not this is a positive or maybe a maladaptive strategy, and then understanding what it does for them as well, right? So what is helpful about this, what is not helpful, and being able to provide that education. Yeah.
Mm-hmm. We've had cases in certain settings where multiple members have presented to hospital that we find out are in the same friend group, and there's a pattern where they're all doing self-harm behavior, suicide attempts, and they're sharing that with each other, right? And so it's super helpful, like Chandra and Margot were saying, you know, do you talk about this with your friends? What sorts of things do you talk about? Do you find it's a positive source of support? Do you find it it impacts you or makes you a bit more overwhelmed or stressed out? As a group, where are they all getting their information? Things like that. Educating young people on their diagnosis. So again, helping them find accurate and evidence-informed places to learn more about their diagnosis or supports they have, and teaching them how to set personal boundaries with others. So we've talked a lot about how like young people are really trying to figure out who they are, and it's really important to feel like they're part of something. And so with teaching them boundaries, you're helping them learn to individuate from peers and base decisions off of their own values. And so can be really easy to go along with the same behaviors others are doing, but helping them say, hey, is this in line with what you want to be doing? Like, what are your values? How do you feel like you are being impacted in the group? It's okay to think for yourself or have any of your own decisions on that. Kathleen has said, remind them to be themselves and not everything is fact on the internet. Totally. I mean, we fall for it all the time. It's not just with young people. We adults spread misinformation all the time online, right? So explore whether they talk about self-harm and mental health with their friends and what sources of info they're accessing regarding these topics. So we've touched on that a little bit, but being able to send them to some websites with some really accurate information, so they're not just getting their information from TikTok or Instagram or places like that. There are some helpful conversations and resources on those sites. And I think social media has been a way of really normalizing mental health and having communities come together on those topics, but just making sure that young people are getting accurate information from other sources too. And help them talk about ways to prevent. Yeah, absolutely. Prevention, I think, is huge with this. And then lastly, depending on your setting, it might be creating guidelines around this. So I'm talking here more about if there's a really negative group contagion where maybe one individual is really negative, not wanting to participate in anything, complaining, making other people feel like they can't share in group settings or be vulnerable. So it might start with speaking to that young person one-on-one, helping them build insight into how their actions are affecting others, understanding where that's coming from for them. And then being straight up with them. Hey, like, this is really influencing the group. Is there a way we can have you feel like you can voice these concerns, but maybe you voice them to one of us rather than talking about it with all your friends on the unit, which is impacting their experience here. In very rare examples, but I have seen it happen. There are times where if everything else has been tried, there might be someone who is discontinued from a program if they are really preventing safety, community, and like a place where people can feel like they're getting a therapeutic benefit in a group. But we often will try everything else because we really don't want to have someone miss out on the opportunity for treatment. So any last comments on social contagion before I move to group dynamics? Okay. So group dynamics, conflict. Conflict is a leading cause of early dropout and reduced treatment efficacy in therapeutic programs. This is no surprise to any of us, right? We don't like being in conflict. We know how conflict feels. While conflict is challenging, if it's managed well, it can actually lead to better group cohesion and a lot of really helpful learning for patients. So we all have likely at some point in our lives learned about the stages of team building. I'm going to butcher it right now, but it's like forming, storming, norming, performing, something like that. And storming is a natural stage of that, right? There will be parts where people are testing limits, butting heads a little bit and figuring out how to balance in a group. So in a residential or inpatient program, you will have a bit more time and program opportunity to teach those relationship skills than in a hospital. So things like effective communication, getting along with different personalities, what we say, how we say things. But no matter what setting you're in, you can definitely use conflict as an opportunity for learning and a way to grow client self-awareness and skills. Outside of your program, they are going to encounter people they disagree with or who really push their buttons, right? And so how can we use this as a way to build up some coping skills for them? So what are some common sources of conflict in your settings? What might be some things that can cause conflict? Either between a client or a patient and clinicians, or patient to patient? What are some common sources of conflict? Medication. Yeah. Could you tell us more about that, Kathleen, with what you're thinking around the medication? Is it about whether to use medication or not, or?
Hi, sorry, my name's Susan. It's a group of us that all work here.
Even better.
I just mean like a lot of our clients specifically don't have a lot of insight into their conditions and they fight the medication. Like they're always wanting to get off the medication, or they'll do everything in their power to avoid being around on the day they need to get their injection. So yeah, it's like a really big conflict a lot of the time.
Totally. especially if there's any like paranoid beliefs or delusions too around my care team is trying to make me take these things for a certain reason. Yeah.
Yeah, we have that. Yep.
Are you all over on the ACT team over there?
Yes.
Oh, awesome. So great to have you.
Deborah here has a comment, feeling misunderstood or judged. Totally. And that goes back to what we talked about, having that non-judgmental attitude when we're working with young people, especially. They might not want to interact with you, and you might come up with a lot of resistance if they're feeling like they're misunderstood or judged by either their people around them or even you as a clinician. Yeah. And then clients who are attending because they're compelled by a third party. This is so big. And this is, think we see this a lot with substance use, that this is part of their conditions and they're like they have mandatory substance use treatment or counseling. It's not going to be the same as somebody who is wanting to come here voluntarily. And that was something we went back to, the importance of engagement and the importance of voluntary engagement, especially when we're looking at treatment outcomes. So that's a really big point. Thank you, Dawn.
Some other common sources, and I see some people typing, so please send in any more ideas you have. Things like relapse, especially in a group setting, if people are working towards a similar recovery goal and one person relapses, that can have an effect on the entire group. Care plans, personality types and clashes, rules, right? Nobody likes rules. And on most hospital units, most treatment programs, there are some rules that need to be followed. Age differences. Maybe some of the younger members, or nothing to do with age, but maturity level might be kind of annoying some of the, maybe the older or the people that are a bit further along in their recovery. Or again, those older people might be acting a bit condescending towards the younger ones. Ongoing substance use. And by that, we mean there's times when someone is on substances and it might be harder for them to control their emotions. They may get angry. They might have unintentional effects on the people that are around them on their unit or in their program. Group difficulties. So, one person's monopolizing all the attention, one person's not contributing at all. Concurrent disorders can complicate things as well, right? Depending on how they're doing with their mental health or their substance use or their withdrawal, there might be changes that are leading to that person just having some basic needs where they're frustrated and not feeling great. Negative attitudes, inconsistent attendance, Maureen has said, yeah, absolutely. Feeling like they're being rushed through a process. Yeah, intake questions or groups, or feeling like the nurse or the person working with them is in a rush and they're not being given the time they need. Absolutely. So what are some ways to manage conflict? And we're wondering preventatively, right? We all know best practices. Can we put all these things in place to prevent conflict from happening? But as all of you know, there are times where conflict does occur and we want to feel like we can respond. What are some strategies some of you have used or heard about for managing conflict? Preventative, reactive, both? Yeah, setting group norms and explaining processes and the reason behind them ahead of time. Totally. So whether that's a hospital unit where there's a bit of a brochure so people understand what to expect, visitation, things on the unit, whether that's more in community or in a specific group even, right? I often like to say that even if you're in a program and there are smaller therapeutic groups, having specific kind of group contracts or agreements within each group for what will help people feel like they can share and feel comfortable. Totally, Chandra. Margot said, acknowledge upfront the difference of opinions will occur, normalize it. And yes, absolutely. So teaching, hey, we are all different here. We have different backgrounds and opinions. We want to kind of know that will come up, but how can we respect different opinions and navigate that as a group? Totally. Some form of mediation. Yeah, absolutely. And depending on what stage that's at, right, Bryce, that might be a pretty simple way of mediating, or if it's been going on for a while, it might be something looking a bit more formal, like sitting down with them and facilitating a bit of a conversation. providing a clear rationale for limit setting that is not personally confrontational. Absolutely. Yeah, Don brings up a great point. People will need to have their own boundaries and limits here, right? And putting those limits in place can almost feel like assertiveness or a bit of conflict in itself, right? Yeah, those touched on a lot of the ideas we had, so feel free to keep putting those in. We've talked about co-constructing community agreements with clients for your program and specific groups, and revisiting them often, right? Hey, are these still working for us? Do we feel like these are still all being respected? Some others are things like building patient and staff awareness of early warning signs. So not only, I think as staff, we know kind of the early stages of when someone's escalating and how we can have nonviolent conflict resolution. But even just for that patient, just talking to them and saying, hey, before you have gotten really angry in the past, what are the kind of the first signs that you're starting to get upset? Is it you notice there's a bit more tension in your body, or you're clenching your fists? Is your heart beating faster? Or do you start to feel a bit hot in your face? How can you tell that you're becoming frustrated or upset? And teaching them about finding ways to identify that in themselves and maybe take a step back or ask for a break before things progress to that next level. Building patient insight into personal or iceberg factors impacting theirs and others' moods. So some of you may have heard of the iceberg metaphor. I really like to use it with people, where if we look at the surface of the water, we see the iceberg and it looks large, but below the surface, the majority of the iceberg is hidden, right? And so that iceberg above the surface are the behaviors we see a person do, but what we don't see is everything below the surface. What else happened for them this day, this week? What has gone on in their past? They might be going through some really difficult things, and so all you're seeing is a behavior, but really humanizing and understanding that that is likely coming from somewhere, and they might be having a hard time. There's a concept in psychology that many of you might have heard about called the fundamental attribution error. It's one of my favorites because it's where if someone else has a behavior or an action, we tend to attribute it to their character or to their personality. So if someone showed up late to a work meeting, I might think, oh, you know, that person's lazy, or they're just not prioritizing things with our team. They're not respecting our time. But then if it's something to do with ourselves, so if I was the one showing up late to the meeting, I would tend to attribute it to external factors. So, oh, the traffic was really bad today, or oh, my computer wasn't starting up on time. And so just acknowledging that we really do want to give other people the benefit of the doubt, and we have this natural bias to assume it's something personal with them. Allowing time for individuals to cool down before having a discussion. This sounds really self-explanatory, right? As soon as someone has flipped their lid and they are fully upset, that's not a time to rationalize and try to have logical conversations and problem solving. Many units might not have access to a full sensory room. There are ways to get creative with this. We've seen like Richmond Foundry, for example, has a patient family room, which they'll sometimes has couches. They'll sometimes put a few sensory items in there. I've also heard about some hospitals that have a seclusion room, and rather than using it in that moment as a seclusion room, having it as like an open door thing where they say, hey, do you just want somewhere for a couple minutes where you can just be out of the noise, and you know the door's not locked, it's voluntary. They can bring in some sensory items and just regulate themselves. It's not a punishment, but a way for them to feel like they can take a space if they need it. So some ways to get creative there with some of the constraints we have with our resources. As you all know, there's times where we may need to make sure that everyone is safe. And so there might be times where you do need to request support from security if staff or patients might be at risk of their safety. Yeah, and then I think above we talked a bit about mediation. Yeah, Bryce was saying mediation. So maybe it's checking in one-on-one with the people involved in the conflict and just saying, hey, well, like I want to hear what's going on for you, hearing their side, and then at some point bringing them together. Setting some ground rules in that session before it starts about some ways to respect each other. Some of my favorites, I used to do some like parent and teenager sessions or couple sessions, and it would be things like one person at a time, using I statements rather than you always do this statements, a focus on us versus the problem, not you versus me. allowing them to take breaks if they feel like they are beginning to get upset, things like that. And in hospitals or different places, we've all seen it where maybe you actually move a patient bed location, right? If people are continuing to really trigger each other and clash, it might be that the best thing for both of them to just continue with their recovery is to have a bit of space from each other where possible. And the last thing I'll say is uniting groups around a common goal. So this is a bit more feasible in a community setting or in a therapy group, but even though they have their differences of opinion, they might clash. If they're working together on a common goal, like a game or a bit of a challenge, or if they're doing good for the community. I worked in New Zealand, and there was a concurrent disorders unit for youth, and they had a group called the Good Bitches Baking. And it was a bunch of them getting together and making baked goods and then donating them to soup kitchens and seniors' homes. And they felt really good, like they were doing something for their community, but also working together on it, which really helped with group cohesion. So a couple other ideas there. Any last comments about that before we keep going? Or questions? So the last thing we'll cover today around group dynamics is challenging behaviors. So for this example, we're talking about it in a group setting like group therapy, but we recognize this looks different for everyone. But we might encounter some challenging behaviors or personalities on our units or in our groups, right? Some of my favorite characters, the overly talkative one who really monopolizes discussions, the one who doesn't want to participate or share in a group. Many reasons for this, again, right? Might be that they're quite shy. We don't want to assume that they're being uncooperative. There's many reasons for why they might not feel comfortable. The one who becomes emotionally dysregulated in the middle of a group, and it's you and a bunch of people, and you're like, oh, how do I navigate this while managing the group? So what are some strategies that can address characters or situations like this? Just being mindful of time, I might read, and I know we've gotten you to participate a lot today, so some of you may be getting a bit of participation fatigue, but feel free to post in the chat if you have any additional thoughts. But you know, having at least one co-facilitator. When there's at least two of you, one person can focus on leading the activity, the other can help manage those group dynamics or take someone aside if they're needing a bit of support or a debrief during an activity. Building in different methods of participation. So maybe turning to the person beside you is a bit less intimidating than sharing in front of a group. In a session like Steph and I's today, when I'm in a Zoom education, I don't always feel comfortable unmuting and talking in front of a group of people online. And so where we can, how can we make there be multiple ways for people to participate? Maybe writing things down in the chat or on a Post-it note, putting it up on the wall so that everybody can walk by and see what everyone else has contributed, things like that. Avoiding calling people out in front of the group. We don't need to be saying this to any of you. I know this is something that we all really aim to do, but just as a reminder to all of us, praising in public, criticizing in private. So if there are challenging dynamics we need to address, maybe asking someone to stick around at the end to check in with them about something, but ensuring that the other group members aren't seeing things like that happening where possible. And redirection in a positive way. So for that person that loves to monopolize the discussions, you know, it's coming from a really good place. They're enthusiastic. They want to be there. So, you know, can we assign them other jobs to help out? Do they want to be a scribe and write things down, which gives a bit more space for others to talk? Do they want to be involved in passing things out or taking more of a leadership role? How can we kind of use their energy but redirect it in a positive way? So just moving to the end here, by the end of today, we hope that you've been able to learn a bit more about positive childhood experiences and how these can buffer the impacts of adversity on young people. We've identified strategies to develop therapeutic rapport, as well as communicate and engage with young people. We've understood a bit more about social contagion and group dynamics, and we've identified some strategies for managing those. So we will be sending out a copy of these slides on our website, and feel free to reach out if you'd like us to email them personally to any of you. But some resources here include things around motivational interviewing, emotion-focused family therapy. We also have more resources for caregivers and for clinicians around family support services. Family Smart has a ton of resources for parents, caregivers, family. There's groups. There's lots of resources online for them. The Sash Bear Foundation as well has like webinars with experts who can provide further information for caregivers on ways they can support their young people. They also offer DBT informed free groups. So whole lot of resources there, not an exhaustive list. But on behalf of Steph and I just wanted to thank you for coming and listening today and for sharing all of your experience. Definitely learned a lot from all of you already. So if you do have questions or you do want to reach out, we do have our emails up on the screen here.
Oh, you're not typing, Susan.
Oh,
Please send the slides to the ACT team.
Oh,
Oh,
we will,
yeah.
yeah, we'll be sending them out. Yep.
Yeah, and just wanted to leave a bit of space here for questions. We also have a post survey. It shouldn't take more than a few minutes. So we'd really appreciate if you could do that now. It really helps us know what you liked, what you'd like to see different. So
okay.
Sure.
Please send the slides to an ACT.
It's just Richmond.
ACT team, do you want me to mute you or do you want to stay on voice?
Oh my God, are we talking right now?
We just want to make sure we get the slides.
We will 100% get you those slides. So don't worry if you didn't take notes on everything